Welcome to our first parent and caregiver education webinar in our Winter Everything Epilepsy series. My name is Gretchen Knob, and I'm the Regional Director of the Epilepsy Association of Western and Central Pennsylvania, working out of our Camp Hill office. And I would also like to thank our generous sponsors for this webinar series, Greenwich Biosciences, Zogenix, Neurology, and Aquestive Therapeutics. So now I'd like to turn it over to Mike Pfeiffer from Greenwich Biosciences, and he will introduce our speakers. So Mike, the floor is yours.
Thank you, Gretchen. Hello, everyone. As Gretchen said, I'm Mike Pfeiffer from Greenwich Biosciences. I'm brand new, so happy to be here tonight. Greenwich Biosciences is thrilled to support the work of the EAWCP and joins in their efforts to help people with epilepsy live life without compromise. I'm proud tonight to have the opportunity to introduce Dr. Todd Barron. Dr. Barron attended Mount Sinai School of Medicine. After graduating, he completed his residency and fellowship at Children's Hospital of Philadelphia. Dr. Barron is board certified in psychiatry, neurology, and child neurology. He's been a physician for over 30 years, working at WellSpan for the last 17 at their Manchester and Gettysburg locations. Dr. Barron is the Associate Medical Director of WellSpan Neurosciences Site Director and Pediatric Neurology. He is an integral part with the entire neuroscience service line, including the EEG laboratory department. So thank you, Dr. Barron, for all you do for patients affected by epilepsy and for being with us today.
Thank you for having me tonight. I'm a little under the weather today, so I may not be as animated as I usually am, but I don't have COVID. It's just a little GI bug. But thank you for having me. So here's sort of our roadmap for tonight. And we're going to talk about seizures. We're going to talk about seizures versus epilepsy, how we make a diagnosis, treatment strategies. We'll sort of get to the middle of the country, talk a little bit about outcomes, and then I kind of do a little bit of comorbidities. And really, this is meant to be sort of a very sort of top level kind of view of epilepsy. And certainly at the end of the talk, I'm happy to get into some of the weeds if people have questions. So first we'll talk about a seizure, and a seizure is a transient occurrence of signs and or symptoms due to an excessive or synchronous brain activity. So you think about a population of nerve cells that are misbehaving and firing in a way that leads to a change in either motor movement, such as sudden twitching of a limb, face, or the entire body, a behavioral change, such as a sudden arrest of activity and staring without responsiveness, a funny feeling, like a rising feeling in the chest or butterflies that sometimes precedes, let's say, a temporal lobe seizure, or an autonomic change, a sudden change in heart rate. And we'll see that, for example, sometimes in individuals with focal epilepsy, we'll actually see a rise in heart rate before they have their typical seizure. These changes are paroxysmal, they occur out of the blue. When you think about someone with epilepsy, they're their regular self all the time, except when they have their seizure. They'll be fine, they'll have their seizure, and then they're back to baseline after a period of time. And typically the seizures are stereotyped, they're pretty much all the same, and they're discrete phenomena. Getting back to what seizures are, we think of them as having a beginning and a middle and an end. That's sort of, they're not this long drawn out affair unless someone has a prolonged seizure. They typically last 15 seconds, a minute, or so on. So we think about normal brain activity as, one nerve cell communicating with another nerve cell, releasing neurotransmitter. What happens with a seizure is there's much more neurotransmitter released, and you get an abnormal response from the receiving nerve cells. When we think about seizures, we think about reactive seizures versus epilepsy. So reactive seizures are not epilepsy. They are due to a reversible transient derangement in brain function. So the most common one that people think about is a febrile seizure in a child. Baby gets a high fever and they have a seizure. They can have one, they can have multiple over years, but that's not epilepsy. It gives them a risk of epilepsy, a relatively low risk, but it is not epilepsy. Someone is playing a football game and gets their bell rung, and they walk away and then suddenly have a seizure. That's in reaction to the trauma. Someone who has massive diarrhea and develops either a very high sodium or very low sodium can have seizures as a result of that. But that's not epilepsy. That's a reactive seizure. And there's various medications that sometimes can cause seizures. When we think about seizures, we think about those that arise focally from one area of the brain and those that are generalized, that arise from the entire brain. And generalized seizures are involve complex interactions between the cerebrum, so the both hemispheres up there, and the cortex and deeper structures such as the thalamus. Whereas a focal seizure seems to arise from one area of the brain, the frontal lobe, the parietal lobe, the temporal lobe. We define focal seizures by their clinical features, what the patient does, their hemispheric location, which is it the right hemisphere or the left hemisphere, and their lobar location, is it from the temporal lobe or one of the other lobes. We define generalized seizures by what we see. They can be convulsive, so that's the one that everyone always thinks about. The patient falls to the ground and has generalized twitching of all four extremities in their head. A tonic seizure where the patient stiffens, I guess, I don't know if you can see me, stiffens like this for a few seconds and then stops. And there are what we call non-convulsive seizures, absent seizures, which are probably the more common that people are familiar with, these benign staring spells, or what used to be called pedimol, and akinetic events where patients have almost like someone pulled the power plug out from them. They pull it out, they fall down, the plug gets pushed back in, and they stand back up. And those can be very, very problematic because patients can injure themselves. And then there are myoclonic seizures. And I'll just give you sort of a pictographic that I stole from Epilepsy Action in Australia. And so the focal onset, we've been redefine them. They can be focal aware. So the patient says, hey, my hand is twitching like this and I can't stop it. They're fully awake. They can be focal onset and they can have impaired consciousness. So they'll be staring, they'll be talking, they might be fumbling with their hands or lip smacking. They're not fully unconscious, but they're not aware. And then any of these can progress to what we call bilateral tonic-clonic, so where both hemispheres are involved and the patient has a convulsion. When we think, once again, generalized onset, they can be tonic or other motor, they can be non-motor. And then we have those that are unknown onset, where we have patients where they may have, let's say, convulsions, their EEG is normal, they're normal, and we don't really know if the seizures are arising from one part of the brain or elsewhere, or the whole brain, I'm sorry, not elsewhere. Now, epilepsies, we've changed the definition since 2014. So when I started training, we said, you have 2 or more seizures, you're defined as having epilepsy. And then people began to ask the question, well, if you have 1 seizure and you have an abnormal EEG, why doesn't that person have epilepsy? And there was a lot of arguing back and forth about that. And I'm not that smart where I can wax eloquent about those arguments. So in 2014, there are basically three components to the definition. You can have 2 unprovoked seizures, or what we call reflex seizures, more than 24 hours apart. Or you can have 1 unprovoked or reflex seizure and a high probability of having another seizure over the next 10 years. And that depends on clinical scenarios. So one scenario where I might think about that is I have a patient who presents with a convulsion. They have a strong family history of epilepsy. Their mother had seizures, grandmother had seizures, mother's brother had seizures, and their EEG shows generalized spike wave discharges. In my mind, that patient has a really high risk of having a second unprovoked seizure, and we might discuss starting medication even though they've only had 1 seizure. Or they have a specific epileptic syndrome. So for example, 6-year-old who is reported to have a single staring spell, and has 3 Hertz generalized spike wave, they have absence epilepsy. We know they're going to have more seizures. Just looking at some statistics with epilepsy, 1.2% of the US population has epilepsy. That's about 3 million adults, 470,000 children, and more striking is 50 million people worldwide have epilepsy, and 80% of them live in low to middle income countries. So it's a very, very common diagnosis, and that 1% is probably true worldwide as well. We can see here, I'm going to just minimize this, the states with more common, where epilepsy is more common, and I can't tell you why it's more common in some of the southern states as opposed to elsewhere. We talk about epilepsy as a disease of the young and old. I'll try to bring back my screen a little bit. And this graph, it's amazing. This is a Helmer study in 2015 based on data from commercial insurances and Medicaid. The more traditional slide is from Hauser in Minnesota. but basically what you see are two peaks, one in early childhood and then one in later adulthood. Once again, it is a disease of the young and old. Now, when we think about epilepsy, we try to classify, what the individual has, and that's based on age of onset, young, old, infant, teenager, cause, do they have head trauma? Do they have a genetic syndrome? The seizures that they experience, do they have just staring spells, or do they have myoclonic jerks, staring spells, and convulsions upon awakening? The pattern of seizures, do they have it only if it's a woman of childbearing age? Do they only have seizures when they have their menses? The severity, is this a kid who has a seizure once in a while and is seizure free on medication? Or is this someone who has multiple seizures and has failed multiple medications? Is this an epilepsy that is something that just appears in childhood and is outgrown, or is this a lifelong epilepsy? What does the EEG show us? What is the prognosis? In other words, are they going to outgrow their epilepsy, or is it something that's going to be lifelong? And then what's become very important in now the second decade of the 21st century is genetics. We now are beginning to define our disorders based on genetic findings. So for example, if I see a girl who's 7 or 8 years old who has difficult to control epilepsy, I'm going to be thinking about ordering specific genetic tests. Maybe she has something called PCDH19, which is one of the epilepsy syndromes associated with difficult to control seizures in girls of young age. The interesting thing about PCDH19, for example, is when we think about prognosis, is they have very difficult to control seizures in childhood, and by the time they reach adolescence or young adulthood, very often their seizures become much better controlled. And it's not understood why that is the case. What are the causes of epilepsy? As we just mentioned, genetic factors are playing a major role. And there was even a paper recently about acquired epilepsies, let's say epilepsies that people have after strokes or trauma, that there's even a genetic input into those who are at greater risk for developing seizures after trauma or a stroke, as opposed to someone who's born with a genetic predisposition for epilepsy in general. Trauma, structural brain abnormalities. We now know there's a whole class of disorders called autoimmune encephalitides. So just like there are autoimmune diseases that affect the joints, like rheumatoid arthritis, and lupus that can affect the kidney and so on, we now know that there are autoimmune disorders that can affect the brain and cause seizures. One of the more common that we're now seeing more and more is something called anti-NMDA receptor antibody encephalitis. People who've experienced a vascular injury have a risk of seizures, and babies who've had perinatal injuries have a risk of seizures. Now, how do we make the diagnosis? And to quote one of the people who trained me a long time ago, Sam Tucker, who's unfortunately passed on, is he would say, Barron, history, history, history. It's really what is the story that the parent, the spouse, the partner, the child, the person, what's their story, what happens? And that is the key to the diagnosis of epilepsy, is the story that the individual tells. And then there's all the rest. There's obviously, we do a physical neurological examination. We always do an EEG, and then there are different types of EEGs that we can consider. We do neuroimaging, and not every case of epilepsy we do neuroimaging, but we typically will do MRI. Sometimes we'll do PET or SPECT scans, which are more specialized studies. There are even more specialized EEG type studies such as magnetoencephalography, which is a different type of EEG using essentially magnetic waves in the brain. And then there are specific laboratory evaluations that we might consider, such as genetic testing. Now, what is it about the EEG? I mean, is the EEG, does it make or break the case? And the answer is no. It can distinguish between epileptic and non-epileptic. The thing to remember is 50% of patients with epilepsy will have a normal first EEG. So, for example, I'll see a family in the office and the child may have had 2 seizures, and I'll say, well, the EEG was normal. And they say, well, how could it be normal? They have epilepsy. And the answer is, remember, that EEG is only 40 minutes or 20 minutes of your brain's daytime experience. And so if you have an abnormality that shows up once every 4 hours, you may not pick it up. Conversely, 3 to 5% of children will have EEG abnormalities and will not have a history consistent with epilepsy or have epilepsy. So what are the kids that we see this in? Oh, we may have a child who has migraines and someone orders an EEG, or a child with attention deficit disorder and someone orders an EEG, and they'll have an abnormality. And by history, they don't have seizures. They just happen to have an abnormal EEG. Now, are there things that mimic epilepsy? And the answer is yes. In infants, one of the more common things that we see is something called benign shuddering. These are paroxysmal events in young infants, maybe they're 5 or 6 months of age. Parent will come in and they'll tell us, you know, my baby's having these funny events. They'll bring a video and they'll say, it looks like as if someone dumped a bucket of ice water down their back. They just shiver very briefly and they go on with their activity. It is a benign movement disorder of childhood. Another common thing that we see is sleep myoclonus. You know, you can watch a baby when they come home from the nursery, and when they enter dream sleep, unlike us, they're moving their limbs, they're twitching, they're jerking, because unlike adults, their brains do not turn off their spinal cord when they're asleep, and so while they're dreaming, they're moving. The way you distinguish that from anything else is you simply wake up the baby and the movements stop. And then there's benign myoclonus of infancy, which occurs in wakefulness. In older children, you'll see things like breath holding spells, various migraine variants, something called paroxysmal dyskinesias, which are these very unusual disorders where children will develop these very bizarre movements that occur paroxysmally without loss of consciousness, and they actually are a channel, what we call a channelopathy. And very often we refer children who faint to evaluate for epilepsy. And some individuals, when they faint, they will have a couple of jerks when they hit the ground. That's what we call a reactive seizure, or what we call a syncopal fit. There are some things that are absolutely not epilepsy. Directed violence, you know, the kid who comes home and looks at mom, and when she says, oh, how was your day at school? And the kid, you know, punches mom in the face, even though that child may do it every day, that's not epilepsy. Rage episodes, individuals, both children and adults, who with minimal provocation fly off the handle with extreme anger, violence, they'll break things, they'll be sweating, their pupils may dilate, and then interestingly, it ends, they're often very tired, and they're often remorseful for their behavior. Masturbation in young girls is a common epilepsy mimic. They have unusual postures, and very often by reviewing the video, we can reassure parents that this is not seizure, but a normal young baby behavior. Once again, lightheadedness and syncope, and then stereotypies, things like rocking, flapping, spinning. Those are things that are not epilepsy. Those are simply overflow phenomena. So when we talk about treatment, and if you want, I can take a break and answer any questions about sort of the diagnosis portion, or if you want, I can go on and continue. I'll leave it up to the host, Gretchen.
Okay. I think you can probably just, you know, keep on going, and then we'll wrap it up with the questions.
Marshal through, okay. So when we talk about treatment, we talk about rescue, and we then talk about daily treatment. Rescue is treatment that you give when someone has a seizure acutely that is not stopping. And we'll talk about that momentarily. So what is our goal? I mean, ideally, the most important thing is we want to maintain a normal quality of life. I mean, that's our goal in treating epilepsy. And it's not to make kids stupid or to make people fat. It's really want to maintain that normal quality of life. And ideally, that's seizure-free, lowest dose of medications, fewest numbers of medication, and fewest side effects. And in general, both in adults and children, we achieve that for about 60 to 70% of the individuals that we treat. For the other 30 to 40%, it is more challenging. When do we treat? It depends on the clinical scenario and how we define epilepsy. In general, if you have a single unprovoked seizure, about 50% will recur over the next 4 years. And if your EEG is normal and there are no other relevant historical features like absence of family history, no neonatal seizures, no underlying neurological problems, your risk is even lower. However, after your second unprovoked seizure, your risk goes up to about 80 or 90%. So in general, at least in pediatric neurology, we will recommend treatment after the second seizure. Once again, unless there are mitigating circumstances where we feel that after the first seizure, they're likely to have another one. Yeah, in terms of rescue agents, there are now a variety of agents on the market. For years, the only one available commercially was rectal diazepam gel, which you see right here. Is very effective, but from a social viewpoint, it's kind of challenging. You're in the mall, your child or your spouse has a seizure. It's really, it's hard to expose them to give the rectal diazepam gel. And there were other ways. There was midazolam that you could use next to the cheek. It was messy and difficult to administer. Now there are two new products. There's nasal diazepam spray and nasal midazolam spray, as you see pictured here, which are very effective for cluster seizures or for prolonged. They are only labeled for cluster seizures, but many of us have used them in individuals with prolonged seizures, and they are effective. For individuals who, let's say, might have focal seizures with either loss of awareness or without loss of awareness, sometimes we can give an oral agent such as oral clonazepam or lorazepam under the tongue or next to the cheek to stop the seizure. Now, I think for many of our families, when we think about treatment, I sometimes wonder if they think that I go out of the room, spin a wheel, roll the dice and say, well, this is the medication I'm going to use. And the answer is no, that's not how we do it. I mean, I think we try to put a lot of thought into choosing the best medication for the individual based on the various circumstances, not only their seizures, but their other problems. So for example, we choose treatment based on seizure type, age of onset. So there's some medications that we prefer to use in younger individuals, and there are medications that we don't like to use in younger individuals. And the same is true in older individuals. So for example, medication called carbamazepine is just very poorly tolerated in older individuals. Even when you start at the lowest dose, they just don't tolerate it. Gender is important now. I mean, there are factors that impact ovulation, menses, and so on. And so there are medications that we prefer not to use, for example, in women. Specific syndromes, there are medications that are better for certain syndromes versus others. Once again, genetics. What are the other medications the individual is taking? Because we have to be mindful of interactions of those other medications. What is the side effect profile of the medication? What are the concurrent medical conditions? In other words, what are the other medical problems that the patient has that may impact, for example, absorption of a medication or otherwise? And then compliance is important. There are medications that are 3 times a day, and I'll tell you, as a parent and a physician, when my child had otitis media and we had to give the Augmentin or the amoxicillin, 3 times a day, somehow at the end of the 10 days, we had a little bit left over. And so I always say to myself, if I can't be 100% compliant on a 3-time-a-day medication, I really can't have that expectation of my patients. And so we really we look at medications that will lead to better compliance, because it's challenging to remember to give your medication every day, twice a day or whatever. Is there a potential for disease modification? In other words, if we treat with a particular medication, is it going to lead to a better outcome? And I will give you just a brief example of that. The NIH sponsored a large study looking at absence epilepsy, looking at 3 different medications. And I'll just be brief about it. And what they did is they followed these kids for a number of years. I think that study's now probably 15 years old. And what they found is that children who were treated with ethosuximide, which turns out to be the oldest drug available for that type of epilepsy, actually had a better outcome than the children who were treated with the 2 other drugs, divalproex sodium and lamotrigine. The children treated with ethosuximide had a greater chance of becoming seizure-free and coming off medication than the children who were treated with the 2 other medications, suggesting that somehow treating with ethosuximide might modify the outcome of the disease. And then obviously, I hate to say it, we must always have to be mindful of cost, and we have to be mindful of insurance. I mean, there are 30+ drugs or so now, and the insurers, always want us to use the cheapest drug first. And, I'm not going to argue one way or another, good, bad, but we have to be mindful about that. When we choose treatment, we think about medications, single drug, 2 drug. And what we always try to do is we always try to optimize the seizure control or side effect. It's not uncommon that any of us will see a child who's failed 5 different drugs, and the reason why they failed those drugs is no one ever increased the dose. They started a little bit, it didn't work, they switched to another drug, it didn't work. And really they didn't fail the drug, they just never had an adequate trial. There are dietary treatments such as ketogenic diet, modified Atkins, low glycemic index therapy. And those we do use fairly often, although I'll be honest, we've been using them less because of all the new drugs that are available. And they are a very effective treatments, but remember, when we think about maintaining normal quality of life, those diets are not necessarily a normal quality of life because they're very restrictive in terms of what children can eat. And then there are surgical strategies, focal resective, removing a piece of the brain that is causing seizures, but is not what we call eloquent cortex, in other words, brain that does something important, like move your arm. Lesionectomies, where there's a clear lesion where seizures are arising from. And there are a variety of stimulators now that are effective. Vagal nerve stimulator being around the longest since the early 90s. There's what we call responsive neurostimulation. There's thalamic stimulator. And then there's an old treatment called callosotomy, which I will say in 30 years of practice, I've only had done in 2 children, one that I recommended and one I did under duress. It remains questionable over the effectiveness of that treatment. And then the other question is, do we really have to treat? So for example, there's a genetic epilepsy in childhood called benign childhood epilepsy with centrotemporal spikes, or benign rolandic epilepsy of childhood. And these are children who typically will wake up, they'll have twitching of their face, drooling, difficulty talking, that lasts a minute, they go back to sleep. There's a very specific EEG pattern that we see with it. And if that's the only seizure type they have, and they have it infrequently and they're not distressed by it, we don't have to treat that because the natural history of that disorder is that children are normal and they outgrow the epilepsy by the time they are adolescents. And so you don't always have to treat the seizure disorder. Now, parents and other caregivers always worry about side effects, and everything that we take, whether it's a medication, a complementary medicine, any food that we always has a potential side effect. And the key that I always say is communication. And I say, if your kid's having a side effect, just let me know. I mean, I'm not married to any of the drugs that I choose. There can be blood abnormalities. Certain drugs cause cognitive changes, such as topiramate or zonisamide. Some drugs cause an increase in appetite, such as valproic acid, and some cause a decrease in appetite, such as zonisamide or felbamate. Some medications can cause behavioral issues. For instance, perampanel sometimes can. Some drugs are sedating. Any of the drugs can cause, any drug that you take can cause a rash. A few cause liver abnormalities, some cause sleep disturbances, and there are some drugs, one which is no longer on the market called ezogabine, vigabatrin, for example, can cause vision changes. I take back what I said. Now, how do we monitor effectiveness? Well, we rely on what the family tells us, the parent, teachers, coworkers, other caregivers. Honestly, the patient is probably the least reliable because many people who have seizures will be amnestic for the seizure afterwards. If we have concerns, we might do longer EEG, such as an ambulatory EEG, where you go home with the EEG for 24 or 48 hours, or we might bring the individual into the hospital for inpatient video monitoring. There are some lab assessments that we do with anti-seizure medications. It just depends on the drug. With some of the older drugs, levels are effective. With the newer ones, probably less useful. With dietary therapies, there's a whole host of labs that we order because nutritionally they are not perfect, and so we'll look at lipid profile and kidney function, things like minerals like zinc and selenium and so on. And then there are some labs that we order specifically for specific drugs. So valproic acid, we might look at a blood count, liver function, and vitamin D. With one of the newer drugs, cannabidiol, we look at metabolic profiles and so on. When we do decide to check levels, we'll check after starting a drug, usually like a trough level, the level before taking the medication. If we change a drug dose, we might check a level. For all drugs, if I'm concerned about compliance, I'll check a level. If we're having difficulty to control seizures and the family says, oh yeah, absolutely, we're giving it, or more typically teenagers, I'll be honest with you. I just had one where the mom said, oh yeah, she's absolutely taking it. The child had a seizure, and then the kid says, honestly, I've been spitting it out. So if we're concerned about compliance, we'll check a level. And then sometimes if we add a second drug, we'll want to check levels. So for example, one of the more common combinations is carbamazepine and valproic acid. And the two can have an interaction where the valproic acid doesn't increase the level of the carbamazepine, but actually increases one of the metabolites of carbamazepine, which causes the majority of side effects associated with carbamazepine. So we'll follow that as well. When do we decide to change medications? If we push the dose of the drug and the patient continues to have seizures, or they develop side effects, or we don't push or they have intolerable side effects straight out of the gate. If there are issues with compliance, so for example, they're on carbamazepine, the plain carbamazepine, which is 3 times a day, or liquid valproic acid, which is 3 or 4 times a day. I've had parents say to me, look, there is no way I'm going to be able to give this 3 times a day. And we just move on to something else. If there are interactions with other medications, we'll add a second drug if we fail at least 1 or 2 therapeutic trials of a single drug. And I'm always trying to assess numbers of medication, and because more does not mean better control. And I really hate it when I have the small population of patients that we all have as neurologists who somehow have gotten onto 3 or 4 drugs, and you feel like, I don't think they're any better, and I feel like I'm giving them side effects. So I try religiously, I'm not always successful, I'll be honest about that, of trying to keep drug numbers to at most 2, but I freely admit I have some kids on 3 or 4 drugs. In fact, I saw 2 today, and they were doing very well, and they were on 3 drugs, and they said, look, we're doing well, we don't want to make any changes. In general, we will aim for 2-year seizure freedom in at least the pediatric population. Obviously, with adults, it's different because we drive. We aim for 2-year seizure free, and if we look at risk of recurrence, about a third relapse after medications are withdrawn, usually within the first 6 to 12 months. If your EEG is normal, you have a later onset of epilepsy after age 2, and you don't have something called atypical absence, your risk of recurrence is much less. But the most important thing is that if seizures recur after a trial off medication, the vast majority, probably greater than 95%, will become seizure-free once medications are reintroduced. So, it's always anxiety-provoking to come off medications, but I find for most of our parents, the bigger anxiety is like, oh my God, if we stop this medication and seizures recur, are we not going to get under control? And the answer is, you have a very good chance of becoming controlled once again after we reintroduce medication. And like anything, there's pros or cons. What's the pro to ending treatment? Well, there's long-term side effects potentially. For many drugs have a negative impact, for example, on bone health. Are there issues with cognitive behavioral effects? I've stopped medications, and parents have said to me, oh my God, I didn't realize this child was so different on medication. As women move towards childbearing years, we worry about medications that can have an impact on the fetus. And there's always this concern about drug interactions, because we all know as we get older, we only accumulate medications, we don't get rid of them, as I learn as I get older. Now, what are the cons about coming off medication? Well, there are always the medical issues. You can have seizures and injure yourself. There are the psychosocial issues of having seizures. And the big one for all adults, or anyone older than 16 or 17, is driving. If you live in New York City, it's not an issue if you have epilepsy. You take the train, they have great public transportation. In some place like central Pennsylvania, if you can't drive, there's a good chance you're going to have difficulty getting to your college classes or your employment. And so it's very interesting as it becomes I try to get my patients off medications if possible before they start driving, because once they're driving, everyone gets very anxious, and I don't blame them. So I'm just going to just do a quick overview. There are many treatment modalities for focal epilepsy. I just threw up some commonly used drugs: carbamazepine, oxcarb, levetiracetam, perampanel. There's a new drug available now called cenobamate, which has the data is very positive on in adults with very significant seizure reductions. Cannabidiol, for example, has just been labeled for tuberous sclerosis and focal epilepsy. And I've used it, even though it's labeled for Lennox-Gastaut, I have used it in some of my patients with focal epilepsy with some success. In patients with focal epilepsy who may have failed 1 or 2 drugs, we always think, is this a patient a candidate for focal resective surgery? Do they have temporal lobe epilepsy, or do they have a lesion where seizures are arising from? And then once again, there are the various stimulators. Dietary therapy does play a role. I will be honest, it's probably not as effective as it is in the generalized epilepsies, but we will try it if families are interested. Generalized epilepsy, and I just give you a picture of a generalized burst. Once again, multiple modalities. And what's interesting, these slides have changed over the years because now there are too many drugs for me to list. The slide gets too busy, but there are drugs like valproic acid, rufinamide, topiramate that are good for generalized epilepsy. Once again, dietary therapy and some of the surgeries can be effective. What's also changed in the last 5 years is now we're beginning to think about tailoring treatment, and I hate using this term because it's gotten overused, this concept of personalized medicine, where actually we look at not only at the seizures and the type of seizures, but we look at the disorder itself and say, are there specific drugs that work for this specific disorder? And the best example is Dravet syndrome, where there have been 2 large studies looking at 2 drugs specifically, cannabidiol, which is labeled, and phenylphloramine, which was just labeled, and both are extremely effective in treating Dravet syndrome. Both turn out to be also very effective in treating Lennox-Gastaut syndrome, which is the endpoint to a variety of different causes of epilepsy. Looking at tuberous sclerosis, vigabatrin if the patient has infantile spasms, cannabidiol, just publications on its effectiveness in treating seizures associated with tuberous sclerosis, and a drug called everolimus, which we use to treat the subepithelial giant cell astrocytomas. Turns out some of the kids who you treat with this drug, which modifies the area in the cell where that's dysfunctional as a result of the genetic defect associated with disorder, some of those kids will have a decrease in seizures. Looking at PCDH19, we're involved in a study looking at ganaxolone, which is a neurosteroid, to see if it's effective in this disorder. The interesting thing about PCDH19 is while in childhood, virtually no anti-seizure medication is effective. And I've had maybe 3 or 4 girls with this who we diagnosed as adults now that testing is available, and their history makes sense. They all had very difficult to control epilepsy, and then suddenly things got better as they hit adolescence. And we said, oh, well, we finally hit upon the right combination of medication. Aren't we great? And the answer is no, we're not great. It's just that their epilepsy followed the natural course of their epilepsy, which is to quiet down in adolescence. Are there other concerns about it with epilepsy? And yes, I mean, patients with epilepsy have greater social isolation. There are employment issues. The Camfields in Canada published some studies looking at people with generalized epilepsy, and even though their seizures were well controlled, they had less successful educational and employment outcomes. Children with epilepsy have a greater risk of educational problems, a greater risk of ADD, depression, and anxiety. And there was a study out of Norway which found that 80% of individuals with epilepsy have a greater than 1 comorbid disorder. In women, we worry about reproductive issues. And then there is this concern for what we call sudden unexplained death in epilepsy patients, which I'll go over in a few minutes. I'd like to touch upon women's health because it is important, and women are different in terms of medical problems. The prevalence is, once again, fairly high prevalence, and there are specific challenges. And I just list these out. There are issues with hormonal changes. 1/3 of women, for example, will have seizures around their menses. There's an impact of anti-seizure medications on sexual function. For example, carbamazepine, phenytoin can reduce libido. They can have an impact on thyroid hormones, and valproic acid certainly has multiple effects in terms of risk of weight gain, polycystic like ovary syndrome, and then the impact of valproic acid on the fetus with greater risks of neural tube defects and greater risk of lower IQ in children born to mothers on valproic acid. If women are on contraceptive agents, we have to be mindful of the seizure drug that we're using, because many of them will lower the effectiveness of the contraceptive agent. There are issues with fertility. And so the important thing is that with any woman with epilepsy, before they get pregnant, it's important to have what we call preconceptual counseling, going over their medications and the risks. Risks in pregnancy are higher risk of congenital malformations, greater risk of preeclampsia. We recommend folic acid supplementation to reduce the risk of neural tube defect, but no one really knows truly what the correct dose of folic acid should be. The the American Epilepsy Society the American College of Obstetricians and Gynecologists strongly recommend avoiding valproic acid in pregnancy and in women in childbearing years because of the risk of the fetus. But honestly, there are individuals who will only respond to valproic acid. During pregnancy, clearance of anti-seizure medications is increased, and so we have to be careful. And even though we don't typically monitor levels with many drugs, it's probably a time that we will monitor levels because at least we can get an idea of how quickly drugs are being cleared. Postpartum, there's always the issue of breastfeeding, and we encourage breastfeeding. Many of the drugs are released into the breast milk, but at very low concentrations, and we generally will try to monitor the mother, but we do encourage breastfeeding because the benefits are so great. I'd like to talk about SUDEP, sudden unexplained death in epilepsy patients, and any of us can have sudden unexplained death. What is sudden unexplained death? My wife, God forbid, can wake up tomorrow morning and I could be stone cold. And she'll say, wow, I really should have paid attention to him when he didn't feel well yesterday. And so as opposed to me walking outside and getting hit by a bus, that's explained. So the definition is a sudden, unexpected, witnessed or unwitnessed, non-traumatic and non-drowning death of people with epilepsy with or without evidence of seizure, excluding status epilepticus. And in autopsy, they don't find a specific cause, like the patient didn't overdose or have some other problem that was unknown that led to their death. We know there are some risk factors for this: male gender, early onset of epilepsy, greater duration of epilepsy, intellectual disability, maybe genetics. We know that individuals with Dravet syndrome may have a higher risk, having convulsions versus focal seizures, having predominantly nocturnal seizures. There's some evidence that sleeping in a prone position puts you at greater risk, just like we think about SIDS with babies, that we preach to new parents not to have the baby sleep in the prone position, but on their side or the back. Number of anti-seizure medications, and non-compliance is a factor. How do we reduce risk? That's $1 million question. Most certainly making sure that patients are compliant is key. Change the sleeping position. So if someone sleeps in the prone position on their belly, encourage them or make it so that they sleep on their side or their back. Improve seizure control. Always address comorbidities. And then there are some seizure monitoring devices. There's the MFIT, which is really a movement detector. It goes under the mattress and it can pick up convulsive movements. And then there's the Embrace Watch, which is labeled by the FDA for seizure recognition. The problem with it only will recognize a convulsion. The technology is not yet there where it can pick up focal seizures or tonic seizures. The other problem is it's a bit of an expense. You have to buy the watch. You have to have a subscription. The patient has to have a cell phone, and there has to be someone else who's monitoring have a cell phone, unless they're in fairly close range to the person with the Embrace watch. I'll be honest, in my practice, people have asked me about it. We've given information about it, and I have to say many parents, I haven't yet to have a parent get one, I think, because it's cost prohibitive. What I tell a lot of our families is start out with a baby monitor or a video monitor in the child's room or the adult's room, and to at least start out with for some reassurance. So what's the outcome? I mean, we treat seizures and like, well, where does this all take us? And I'm going to present a slide in a minute because I think it was kind of an interesting study. Look, I think it was in Norway. They followed people for 50 years with epilepsy, and what they came out with is, if you have average intelligence, you have no neurological impairments, and you have generalized epilepsy, you have a greater likelihood of becoming and remaining seizure-free. Interestingly, what they found in that study is a reasonable percentage of people remained on medication even after they've achieved long-term remission. And then once again, that gets back to the driving issue, in that many people are reluctant to come off medication once they're driving for obvious reasons. Long-term remission rates range from 78% at 12 years to 82 and 90% over 50 years. And I'll show you the graphs. And I'll just show, the graph to look at is, this is group 3, which is the one group to look at. This is mislabeled, that should be group 1. And really, majority of patients become seizure-free and go into remission in the first, 9 or 10 years. And then over the next 50 years, a substantial portion become seizure-free. So for the good news, for many patients, they will become seizure-free. And I know for physicians, we think, oh, no one ever becomes seizure-free, because the patients we think about are the ones who, unfortunately, we've not been successful with. 2 words about seizures and safety, and that is use common sense. There's nothing magical about epilepsy and safety. You just have to use common sense and think about what's a safe thing for my child, my spouse, my friend to participate in, and what's not. And I stole this from the EFA. Obviously, to make your home safer, cook with a partner, use the microwave, don't use maybe non-breakable dishes, be careful with hot foods. And one of the most common injuries that we see in patients with epilepsy are burns. We uniformly tell our patients to take a shower, not a bath. And we tell them to put a non-skid mat in the shower if possible. In the bedroom, we think about seizure monitors, have the bed away from the wall, night tables, and sharp objects, although I don't know what kind of sharp objects anyone's have in the bedroom. If your child has difficult to control epilepsy, yes, parents will pad the edges of their table, keep walkways clear of toys, which as a parent, even though my kids are out of the house, is nearly impossible to keep floors and walkways clear of toys. I always used to say when I would come home, this house has what we call toy metastasis. There's a toy everywhere. And obviously we want to be mindful about power tools, things like that. At school, it's important to make teachers, coaches, school nurse aware of the diagnosis. It's not, this shouldn't hide it, they should be aware so they know what to look for. Provide a seizure action plan for school, and we do that uniformly. We actually, it's a quality project that we're doing at WellSpan to make sure that all children who have specific forms of epilepsy that require rescue, that they have an action plan at school, and we've been very successful. I think we've been at 100% now for 2 months. We provide rescue medication if indicated. And the important thing for parents is to maintain contact with teachers regarding academic performance and behavior, because it's always, I feel bad for parents when you walk in November for parent-teacher meetings and the parent says, well, I'm glad we're meeting. This has been a disaster since September. And I feel like as a parent, you feel like saying, why didn't you call me or email me? What should you do at your doctor's appointment? Well, if it's your first appointment, bring all medical records and images. If there's events that you're having questions about, try to video them. It's so helpful to us because you can show a video to 6 different people and they will see 6 different things. Provide a list of medications, including over-the-counter medications and any supplements you're giving. So with follow-up appointments or the first appointment, speak with the school staff, babysitters. Do they have concerns about not only seizures, but how your child is doing in school? Always write down questions and concerns. I don't mind when parents come with lists. It's actually sometimes, they'll have a list. Today, a parent had a question. Before I even we were talking about COVID vaccination. She goes, well, that was on my list. That's one thing off already. Use the patient portal. It's so helpful. I mean, I don't mind getting emailed. It's efficient. You get answers very quickly. If possible, maintain a seizure diary. I know it's very challenging. We all have very busy lives, and this is one thing that's hard to do. And allow your child to participate and aim for them to sort of run the visit as they get older. We want them to participate. We want them to understand their diagnosis. As opposed to, as they get older, we want them not to be a passive bystander, because they are going to transition at some point to an adult neurologist and may not have their parent with them or always have their spouse with them. So it's important to make them active participants in their visit. So I have some final thoughts. Once again, many options and strategies for managing seizures in children and adults. Goal is always to maintain a normal quality of life, and that's just the key. And I always tell parents, I don't look to trade one problem for another problem. We have to work together, and really management is a team sport. It's patient, parent, family, caregivers, teachers and coaches, and then community resources such as the Epilepsy Association. And with that, I will open it for questions. I'll end sharing my screen.
Okay, thank you, Dr. Barron. So we do have a few questions, and I'm going to start with How common are liver side effects from anti-seizure drugs such as Depakote, Lamictal, Tegretol, Keppra, etc.?
Liver side effects, significant side effects, are very uncommon. So for example, certain drugs have absolutely no impact on the liver, like levetiracetam, breviracetam, gabapentin. So they're not cleared by the liver, so they have no impact. We monitor liver functions, for example, with valproic acid, we will, maybe once or twice. Cannabidiol, FDA mandates that we monitor liver function, but generally in really 30 years of practice, very rarely do I see someone who has significant liver problems. Yes, I've had children who've had liver problems from valproic acid, but those children had underlying metabolic disease that was unmasked by the valproic acid. But by and large, these medications are very well tolerated and have little impact on the liver.
Thank you. Should the liver be medically evaluated prior to taking these medicines?
Generally, for example, with, let's say, valproic acid in adults, we might get a baseline set of liver functions and then repeat them. Typically, though, we don't do baseline liver functions, unless, once again, for example, with cannabidiol, mandated by the FDA, that we get a baseline set. In children, it's very uncommon to find any liver abnormalities on a drug-naive individual. Yes, adults, we have lots of other medical problems and we're on lots of other drugs that certainly can impact liver function. So let's say an adult neurologist might check liver function at a baseline in an adult.
And what anti-seizure drug has the safest record for liver side effects?
Once again, those that don't go through the liver, so that would be things like levetiracetam, breviracetam, and gabapentin.
Okay, thank you. Okay, so we have another. It says, our son, who was active with the Epilepsy Association for years, now 18, has recently decided to quit his medication cold turkey since August of 2020. His seizures for the past 8 years, Okay, so his seizures have now become more violent, longer in duration, and more frequent. It seems he is out of control with what seems like psychological episodes. He has worsened mentally and was hospitalized over Christmas, but still refuses medication. His mental state has deteriorated. What can we do as caregivers of an adult now not taking medication, but risking his life and affecting the lives of our family? It says he has grand mal tonic-clonic, usually lasting between 3 to 4 minutes. He was on, I'm sorry.
Go ahead.
Okay, so he was on, they had tried Keppra, lamotrigine, and Zonegran for him.
Well, firstly, I'm sorry that that's a big stress. And I don't have a great answer, because once individuals become adults, they're emancipated, and it's very difficult. You know, you can lead a horse to water, but you can't make him drink. And I feel for you. It really is. It's really having him hook up with. Now, of course, my son will tell you that I shouldn't use the word hook up, but I'm old, and that I'm using hook up in the old sense, not the newer sense. Just putting that out there. Really, it's making sure that he or she is connected with a neurologist that can work with him, work with a counselor, and try to, first of all, find out why he isn't taking medication. And when you think about it, you can substitute any chronic disease, and this will be the same story. So if this were a talk about Crohn's disease or ulcerative colitis, there would be a parent who says, my 18-year-old refuses to take their immunosuppressive for their Crohn's disease, and now they have a horrible flare and they have fistulas. We see in adolescents with diabetes, they suddenly show up in ketoacidosis because they've stopped their insulin. So this is a very common problem in adolescents and young adults with chronic medical disease. The key is to, and it's not easy, so I don't want you to think that it is to connect them with the appropriate neurologist, connect them with support services that can work with them to first understand why they're not taking medication. Sometimes kids say, I don't want to take that medication because all it does is give me side effects. So if finding a medication that will work and may not have side effects, and then dealing also with some of the psychological, psychiatric issues, which are sometimes a bigger challenge. We know that if you look at individuals with epilepsy, there is a much higher incidence of depression, a much higher incidence of anxiety, and we sometimes have to address those first before we can even attack the seizures. But absolutely, I don't have a great answer. It's a challenge. These are sometimes visits that I have with my patients where it's a long sit-down discussion, not so much with the parents, but with the patient, and say, hey, what's going on here? This is what you're doing to yourself. What can we do? And sometimes, once again, it comes out, well, Dr. Barron, when you put me on Depakote or divalproxone, it just made me fat, and that really pissed me off. And I decided I didn't want to take anything. And I say, well, I'm glad you told me that. Let's find something that'll work that you won't have side effects from, because maybe we can make some improvements elsewhere if we get your seizures under control. Once again, I don't have an easy answer for you, especially once they're 18.
Okay. All right, thank you. Okay, so the next question, I am a nurse and work in clinical trials. One of the things we monitor is adverse events in partner pregnancies. I have 2 boys with epilepsy. Are there any concerns with AED use and pregnancies in partners?
As far as I know, none that I'm aware of in terms of, and I have to say, I can't say that that's been highly studied, but I'm not aware of any significant impact on AEDs in males affecting, the partner, as far as I know.
Okay, and then what's that?
Good question, though.
Yeah, okay. How difficult is it for your patients to be properly transitioned to adult neurologists when they turn 18?
What did you say? I'm sorry, I missed the question.
That's okay.
I was admitting somebody.
How difficult is it for your patients to be properly transitioned to adult neurologists when they turn 18?
Well, I would say that I talk a lot about transitioning, and I am a terrible transitioner. You'll just ask my patients. I am the worst. It is a process. I think when we think about, first of all, we always joke that, the adult neurologists say that, the pediatric neurologists are enabling, and the pediatric neurologists said the adult neurologists are mean. That's not true. But when you think about pediatric epilepsy, many of our patients are with us for 10, 15, 18 years. I mean, it's very, that's not just, that's like a serious relationship when you think about it. I mean, that's like half of someone's life. So it is challenging, and we're trying to do a better job at transitioning and working with families to move to identify adult neurologists, and not only adult neurologists, but primary care doctors that feel comfortable taking on individuals with chronic disease. And once again, you can fill in Crohn's disease, diabetes. It's very challenging. I remember when I was a resident, and as a pediatrician, I had to do 1 year of adult neurology. It was my first night on call in the adult hospital, and I was totally panicked, and I ran into a young woman who had cystic fibrosis, who I used to take care of when at the children's hospital, and she got transitioned to adult medicine. We ran into each other, and we hugged each other because it was a familiar face. And so really it's really working towards families to prepare them for the transition, making sure they have all the information they need, making sure we communicate with the adult neurologist, so that when we hand off the patient, the adult neurologist has a letter and has information exactly what the issues are, so it's not an unknown. What we also try to do when we transition patients is we'll circle back with the family and say, hey, we saw you had an appointment with Dr. X, how did it go? Is there anything that we can help you with? And for example, I had one family, we transitioned to an adult neurologist. The mother, we called the mother, she said, that was the worst experience. Can you find me somebody else? And we did. And then the second experience was much better. But I'll be honest, I'm a terrible transitioner.
Okay, all right. Okay, so we have another question. I have a daughter who is 7 years old. She has been on Oxycart, you know what?
Oxycart.
Yeah, I always mess that one up. For that long, is that okay?
Well, it depends on the circumstances. As I said, generally what we aim for is if someone is seizure-free for 2 years on medication, we will begin to have a discussion as to whether we want to give them a trial off medication. And that depends on what their EEG shows, what their syndrome is, what their genetics are. So for example, if I have a patient with, let's say, absence epilepsy, where we know many of those children will not outgrow the epilepsy until they're through adolescence. And let's say I diagnose them at 7, so at 9, they're not through adolescence, but they're seizure-free. I'll say, well, we can have a trial off. What's the worst case scenario? Is the seizures recur? We put them back on ethosuximide. Other parents will say, well, the EEG is still abnormal. Let's continue until they go through puberty. So it's a conversation between the parent, the child, the adult, and the neurologist. And that is the key is communication. I always tell my parents, don't be a stranger. Nothing stresses me out more than at a 6-month appointment, a parent says to me, oh, I'm so glad we had this appointment. You know what's hit the wall for the last 6 months. And I'm like, call me, I don't mind, email me. Just don't email emergent things. I mean, there's nothing more, because it sometimes takes 24 hours to get to us, and there's nothing more harrowing than seeing an email like, call me, my child's seizures haven't stopped. And I'm like, I guess I'll call right now. Don't email me that.
So I would like to, once again, thank you, Dr. Barron, so much for that great presentation.
Thank you.
Also, I would like to thank our sponsors, Greenwich Biosciences, Zogenix, Neuralis, and Aquesta Pharmaceuticals, and all of you for joining me this evening. I hope that everyone is doing well and you stay safe and healthy.
Have a good night. Everyone stay healthy. Bye-bye.
Good night.